Hello everyone, this is Dr. J and welcome back to the channel. Today we have two patients. First one is a eustachian tube dysfunction that created a serous effusion and operating on an awake patient in the office and ear tube placement. If you want to skip forward to the wax removal, skip forward to 4 minutes and 20 seconds. I understand if you don't want to see this procedure, that's fine. This is a pretty benign procedure. First things first, when you're doing an in-office awake patient procedure, you need to size your speculum. These certain speculums come in different shapes and sizes, and once you find one that fits the patient ear canal then you move forward with that one. Now the goal here, as you see, I'm just gently manipulating it into the ear canal to the point where I am past the hair-bearing portion of the ear canal, and just a slight twisting motion as I'm putting some pressure down inside the ear canal. Obviously, I'm talking to the patient, saying, "Are you feeling this? Are you okay? Are you in any discomfort?" And then once we get to a steady state and I can see the eardrum well, then we move forward with the procedure. This is called a serous effusion, amber colored, and this is kind of a classic adult eustachian tube dysfunction finding, and usually can happen after a cold or upper respiratory infection, or they just have long-term eustachian tube dysfunction and it's been a problem their whole life. Right here we're applying topical phenol, which is a caustic chemical. If you worked in organic chemistry through college or other classes, then you'll know what I'm talking about. It has a very distinct odor to it. Right now we have a micro sponge, and we're just gently placing it onto the eardrum in the area of the anterior inferior quadrant. So if you divide the eardrum into 4 locations: anterior superior, anterior inferior, posterior inferior, and posterior superior. This is in the front lower part of the eardrum. Again, this is the right ear, so the nose would be to the patient, on the window here, the nose would be to the right, and the back of the head would be to the left. This is a myringotomy knife. Once that topical phenol has taken effect and the eardrum is no longer sensate in that area, sorry about my thumb there, then we make a small incision in a radial fashion, and then we use the suction to suction clear the effusion. And this can be quite noisy. And so during this time frame, I'm talking to the patient. I'm coming in with suction. It's going to be noisy. Kind of brace yourself. And so I move to a smaller suction once most of that's cleared out. And just see what else I can get out of the middle ear space. Now, you can't get 100% of this because the mastoid bone behind the ear is also a hollow space, and that fluid can be all the way back in there. So you're not going to get 100% of this out. But once the tube is in place, it'll either work its way out, or the tissues, or what we call the mucosa within the ear, will take care of it. Now, here's a picture of some various types of ear tubes. Tympanostomy tubes, different shapes and sizes and purposes. And so we're going with a standard button, or what we call a collared ventilation tube, or tympanostomy tube. And we just gently tuck it in so the bottom phalange is below the eardrum, and the superficial phalange is resting on top of the eardrum, and that's what's going to hold it in place. And you can see there's just a little more amber-colored fluid there, so we're going to suction that clear. Now, this tube will last anywhere from 6 months to 18 months, and we just monitor them every few months, have them come in to do a quick ear exam, and just monitor that. Usually 95% of the time, it falls out on its own. Now, this next patient came in with hearing loss. His hearing aids were no longer working. He was quite worried about it. And once we did our exam, we could see that he was impacted on both sides, to the point where the tip of the hearing aids are resting up against the hearing aid device, or the tip of it, and rendering it less effective. And we're starting on the right ear here. As we see it, it's fairly mobile. I don't When it's this mobile and it's coming out fairly quickly, I usually don't add any oils or collace to the ear canal. It was moving pretty freely on its own. And just using the Fraser suction here, we're just gently lifting it up away from the ear canal wall. And once you break away from the ear canal wall, it should move out fairly easily. Here we zoom out a little bit as the bigger piece comes out. You can tell it's a little bit darker. It's been in there for a while, a little bit of oxidation on it. Going back inside the canal, there's just a little bit hanging there. Now, most of that skin, there's a little bit of wax with it, but most of that skin or the other word we can use is keratinaceous debris. And I tried messing around with the suction, but it just wasn't ready to come off. So I go in with alligator forceps and just gently remove what I can, and then what I can't move aside, just gently lay it back down, and it will continue to migrate out on its own, and instruct them on some proper topical eardrops to help keep this from accumulating in the future. And moving on to the left ear, this one's worse. This one's 100% impacted. You can see it's kind of concave, so the hearing aids have been kind of compressing this in place, not allowing this wax plug to move out. Again, we use the Fraser, just go around lifting up the edges, and the ultimate goal when we're lifting up the edges is, we're trying to break the suction plane or the stickiness between the wax and the ear canal wall. And so I'm going to be looking here, and you'll be able to see it when I see it. You're looking for that break where you can see past the wax plug and you have a canal wall to work with. So we worked on the back side of the canal, and now we're working towards the front side of the canal wall, and as well as the bottom of the ear canal wall. And you can tell it's soft, but it's stuck decently enough that the whole plug it's not moving. So I know once I get that particular viewpoint, we'll start adding some collace. And you can see there's that layer of shiny skin, and that's you've got to get that up. Otherwise, this will be a much more difficult process. And we're just about there. We're about to see our window of opportunity. And here comes right here. As we lift up, we see that break right there in the lower part. There's a little window back there, and I know I can get some lubrication past that point now. So we apply the collace, and collace goes in. I usually like to fill it up to the point where it covers most of the plug. And we don't have to let this sit. It's going to do its job fairly easily. Just gently manipulate the plug now to try and work it around all of the edges and crevices. And that changes everything. Now the whole plug is going to start to move as one unit. And we're just working it out, turned it to its side, and now I manipulate it out to the outer ear, and a little bit more loose skin there, and here's the big plug. You can see how the ear canal shape is different from where it was actually attached there. And there we go. Nice big plug. Came out as one piece. As we look back into the ear canal, we can see that everything came out with that one move. And thank you very much. Thanks for sticking it out to the end. And as always, thanks for watching. We'll see you on the next video.